So the simple thing there is, if we can take away the restricted muscle and we can make an inhibit muscle move better, then essentially we can allow the psoas to function more efficiently. So that gives us an opportunity then to take a strength measurement. And what we will find in an example like that, when it comes to taking strength measurements, of course we have peak output. Okay, that's fine. That's a lovely little number. But what we also have is how quickly the rate of force development, how quickly can they get up there, and or how quickly can they fatigue. And over what I tend to do with a lot of my dynamometer tests, I do it over 5 seconds. And I say to the patient, look, if you feel pain, just stop. If you cramp up, just stop. And invariably what happens is they cramp in the tensor fasciae lata, because initially they can generate force because I've done some treatment. The muscle feels better for working, but the more force they generate and the longer it goes on, then the muscle fatigues, and of course they have to gain that activity from somewhere else, and that's where the cramp comes from.
Right. How accessible is this form of evaluation in, I'm going to say, a normal clinic? I mean, you're accustomed to working at a different level of athletic prowess to most people, but first of all, I mean, can people buy a suitable dynamometer without expending too much money, and would they know how to use it the way you do without too much training?
Yeah, no, you can buy nowadays. My first one I ever bought was about £600. Nowadays, I bought one recently for about £300.
Right.
You can go on YouTube and they send videos. It's a nice, simple tool. You know what it does for me? It brings osteopathy into a more it helps with our objective testing, where we know in the past sometimes we're criticised because we're too passive, but so that brings things a little bit more objective. And the other thing I'd say is you know, in terms of using it, it's very straightforward. You know.
Right.
I mean, I mentioned it in the book. I'm going to teach a course in Norway this weekend. I'm going to take one with me. I'm going to show the students how to do it, and we'll present the same sort of type of course that I would do in the UK in June as well. It'll be a similar thing.
Right. Okay. And what about you? You mentioned Ober's test, but have you found tests which are reliable and effective in evaluating the spinopelvic hip complex?
Yeah, so the most important thing is there's no one test that stands out. We need a battery of tests. So what I didn't mention at the start, if I looked at that individual standing in front of me and I put them into a single leg stance with small knee bend into a functional position, they may not be able to tolerate that position. Okay, the knee drops into valgus because of lack of force closure through the pelvis because of gluteal insufficiency. When that happens, I can pretty much guarantee that they're going to test positive with some adapted Obers and adapted Ober's test. They're probably going to have some trigger points in that tensor fasciae lata. Their active straight leg raise will, on the symptomatic side, will be more laboured, maybe even be a little bit weaker, Stephen, compared to the good side. Okay, that's an example there of a longer lever activity generating more stress through that anterior hip complex, i.e. the long tendinosus. What I might also find is as a result of this being a long-term grumbling thing, then I've lost active and passive hip extension. So when we put them in the sideline and they lock up their pelvis by holding onto their bottom leg, I know that I can't get hardly any hip extension because of the stiffness in the anterior chain. Not in the psoas, and this is a mistake people make. They think this is stiff, I need to release this tendon, and I put my fingers into it really deep and trigger point it and manipulate it and stretch it off the end of the bed. No, it's not the psoas. The psoas is a weak link. The stiffer tissues, in my opinion, the tensor fasciae lata, the lateral quad, rectus femoris, maybe even some of the high adductors like pectineus or brevis. Those need to be opened up a little bit, okay, to give us more freedom of movement.